Assalamu alaikum. It's the second part of infectious disease where I will discuss the important topics in a very mm, sophisticated manner, in a very easiest manner. We will like to discuss about the usmle inner circle book. usmle inner circle PDF is a very masterpiece PDF for step 2 exam where you will get everything in a concise manner and very high yield for the upcoming exam, upcoming USMLE. Okay, start with infectious disease part 2. It's a part 2 where we will like to talk about the infectious disease. Start with this acute HIV infection. Epidemiology is typically 2 to 4 weeks after the exposure. Initially, it comes with the mononucleoside-like symptoms like fever, lymphadenopathy, sore throat, arthalgia. Maybe comes with some GI feature. There may be macular rash. Viral load is markedly elevated in acute HIV. Viral load is markedly elevated, more than 1 lakh copies per ml. HIV antibody testing may be negative, not yet zero converted. That's why it may be negative, and CD4 count may be normal. Management for acute HIV infection combined antiretroviral therapy like 2 nucleoside reverse transcriptase inhibitor along with an integrase inhibitor. If pregnancy, then comes with a protease inhibitor. So this is the way of combination antiretroviral therapy start protocol. And the partner notification, consider secondary prophylaxis. Now virologic failure is defined as a failure. Virologic failure is defined as a failure to achieve viral load less than 200 copies in within 24 hour within 24 weeks, like 6 months of antiretroviral therapy, and may be due to drug resistance or non-compliance. Following antiretroviral therapy initiation, viral load should be measured approximately every 3 to 6 months. So, what is virologic failure? It is a failure to achieve viral load. Failure to achieve viral load less than 200. Our target is to achieve the viral load less than 200 copies within 24 weeks. So 224, this is the two number you have to remember. We try to reduce the viral load less than 200 copies within 24 weeks, like 6 months after giving antiretroviral therapy. If this does not happen, think about the virologic resistance and try to measure the viral load every 3 to 6 months. In treatment naive HIV positive patients, antiretroviral therapy should decrease the viral load. Antiretroviral therapy should decrease the viral load less than 6 copy within 6 months. In treatment naive HIV positive patients, antiretroviral therapy should decrease the viral load less than 50 copy within 6 months. What testing should be offered for high fever? What testing should be offered for fever, arthalgia, night sweat, lymphadenopathy, prolonged diarrhea, and mucosal ulceration? HIV testing should be done. Fever, arthalgia, night sweat, lymphadenopathy, prolonged diarrhea, and mucosal ulceration. So diarrhea, oral ulceration, rash, diarrhea, oral ulceration, rash, oval, pink, red macular lesion, non-tender lymphadenopathy, no tonsillar exudate will help differentiate from mononucleosis. Diarrhea, oral ulceration, diarrhea, oral ulceration, rash, diarrhea, oral ulceration, rash, oval, pink macular lesions, non-tender lymphadenopathy, no tonsillar exudate. Another common cause apart from enterovirus, another common cause apart from enterovirus is aseptic meningitis in young sexually active adults in acute HIV infection. HIV screen 15 to 65, younger or older if at risk. Treatment for TB, treatment for another STD. Initial screening, treatment for TB, treatment for HIV annual is HIV screening indications. Initial screening age 15 to 65 with younger or older adult if at risk. Treatment for TB and treatment for another STD. Annual or for more frequent screening. IV drug abuser, sex partners, men who have sex with men, sex for money, drugs like HIV, additional screening, pregnancy, occasional exposure for blood or bloody fluid, any new STD symptoms. What screening for STDs should be offered to an asymptomatic 22-year-old male that is not yet sexually active? Uh, the man is not sexually active, but what screening test for STD should be asymptomatic. Testing for HSV, gonorrhea, HIV testing for HSV, gonorrhea, syphilis is not needed in sexually inactive asymptomatic patient. So HSV, gonorrhea, syphilis is not needed for sexually inactive asymptomatic patient, but uh, asymptomatic 20-year-old male comes with a like STD feature. Think about the AIDS. Common causes of diarrhea in AIDS: Cryptosporidium parvum causing severe watery diarrhea, intractable water, Mycosporidium, Isosporidium, watery diarrhea, fever is rare, less than 100 CD4 count, Mycobacterium avium intercellular less than 50, high fever more than 100, true cytomegalovirus, frequent small volume diarrhea, hematochezia, abdominal pain, low grade fever. Azithromycin for MAC not recommended anymore. So azithromycin for Mycobacterium avium intercellular is not used these days. All patients with active CMV require ocular examination to rule out the concurrent retinitis. Opportunistic infection in HIV, pneumocystis, toxoplasma, histoplasma, VZV, toxoplasma gondii, less than 200. CD4 count, history of PCV, pneumocystis, pneumonia infection. Trimethoprim sulfamethoxazole is a prophylaxis. Alternate dapsone, adapaquine, and pentamidine can be used. Toxoplasma gondii, trimethoprim sulfamethoxazole, dapsone plus pyrimethamine plus leucovorin can be given in Toxoplasma gondii. Multiple ring enhancing lesion in Toxoplasma gondii, and atovaquone and pyrimethamine plus leucovorin can be given. So these are the alternative therapy for Toxoplasma gondii. Main treatment for TMP, SMX for Toxoplasma gondii, pneumocystis for TMP, SMX and histoplas for histoplasma itraconazole and VZV varicella zoster immunoglobulin and IG administered within 4 days of exposure. Within 4 days of exposure. Okay, now what is the what is the likely chief complaint in a patient with diagnosed with cryptosporidium parvum, prolonged profuse watery diarrhea, typically 10 to 14 days? What is the likely diagnosis of HIV patient with CD4 count of 25 that presents a 3 weeks of fever, night sweat, abdominal pain, watery diarrhea, weight loss, chest X-ray, CMV serology, BPD, are all negative. Disseminated bacterium avium intercellularly interaction. In disseminated avium intercellular infection, there may be PPD may be negative because it is atypical mycobacterium. PPD sometimes may be negative. You should do chest X-ray. You should do CMV serology. TB and CMV are less likely given in the normal chest X-ray in duration and negative CMV IgG. So what are the vaccines? For adult with HIV infection: hepatitis A, hepatitis B, HPV, influenza, meningococcal, pneumococcal, Tdap. Influenza annually, we know HPV 11 to 26, meningococcus age 11 to 18, 11 to 18 pneumococcus, PCV 20 followed by PCV 15 followed by PPSB 23, Tdap once 2D every 10-year live vaccine. MMR varicella contraindicated if CD4 count is less than 200. These vaccine like MMR varicella contraindicated if CD4 count is less than 200. If CD4 count is less than 200, these vaccines not that important. That's why I'm not going to read this box. Mm, in here, the main theme they above box along with this two nucleoside reverse transcriptase inhibitor. I have told you tenofovir empty cytavin plus integrase inhibitor raltegravir, dolutegravir, elvitegravir or protease inhibitor can be given, or in an RTI like nevirapine can be given. So that is a way of giving. Zidovudine can cause anemia, stavudine can cause peripheral neuropathy, pancreatitis, abacavir hypersensitivity, Stephen Johnson, indinavir, nephrolithiasis, tenofovir, renal insufficiency. Patients with HIV on antiretroviral therapy are increased risk of HIV-associated lipodystrophy. Manifestation are lipostrophy, fat accumulation, insulin resistance, dyslipidemia, cardiovascular disease. And now Okay, neonatal sepsis group B. E. coli listeria. We know that, and ampicillin and gentamicin should be the choice of infection. And antibiotics in pediatric sepsis. If it is less than 20 days, group B. E. coli listeria, ampicillin, and the gentamicin should be given in neonatal sepsis. If it is more than 28 days, streptococcus pneumonia and Neisseria meningitis should be think about. Ceftriaxone with or without vancomycin. Ceftriaxone with or without vancomycin. If somebody has rabies, if somebody has rabies, like rabies post-exposure prophylaxis, rabies post-exposure prophylaxis. If it is low risk wild animal, if it is low risk wild animal, no post-exposure prophylaxis is needed. Squirrel, chipmunk, mouse, rabbit. If high risk animal, bat, raccoon, skunk, available for testing, yes, euthanize and start post-exposure prophylaxis. No, aren't available for testing, start post-exposure prophylaxis. Pet, dog, cat, available for quarantine, no, start post-exposure prophylaxis. Available for quarantine, observe 10 days, no exposure prophylaxis if animal is healthy. Livestock or contact public health department. Human rabies, we know that in human rabies, hydrophobia, aerophobia, agitation, pharyngeal spasm. The in chikungunya caused by the Aedes aegypti mosquito, this mosquito can cause Zika, can cause yellow fever, it can cause dengue too. It comes with a severe polyarthalgia, conjunctivitis, micropapillary rash, there will be leukopenia, thrombocytopenia, supportive care, and if the joint pain is much more, you may acquire methotrexate. Methotrexate, chikungunya. So yeah, a patient comes from a Caribbean trip, comes with a fever, polyarthalgia, and diffuse macular rash, leukopenia, thrombocytopenia. Think about chikungunya virus. Respiratory syncytial virus, age less than 2, then wheezing, crackles, respiratory distress, supportive care. In bronchiolitis, complication is apnea and respiratory failure may happen. Alivizumab in selected cases at less than 28 weeks of gestation, chronic lung disease, this and that. Viral bronchiolitis, increase interstitial marking, peribronchial coughing. Treatment for bronchiolitis is suppurative, nasal suctioning, adequate hydration. Do not give a beta agonist steroid and antibiotic. This is the stable sign for croup, acute parainfluenza, acute laryngotracheitis, parainfluenza, viral infection, larynx, trachea is 6 months to 3 years, and age less than 2 years is bronchiolitis. If 6 months to 3 years, croup, barking cough, inspiratory stridor, and wheezing. Inspiratory barking cough, inspiratory stridor, and hoarseness. Mild humidified ear, corticosteroid, moderate severe nebulized epinephrine should be given. Nebulized epinephrine with silver cough. So adults at high risk influenza infection, age more than 65, women who are pregnant, underlying medical conditions, COPD, cardiovascular, immunosuppressed, morbidity, these and that. Okay. Then the last thing I would like to discuss the very high approach to dinophagia and dysphagia in patients with HIV. I have suspected esophagitis. Mild symptom oral thrush. Go for candida likely and give fluconazole. If symptoms not improve, endoscopy should be done. If severe symptom, no thrush, endoscopy for viral pathology. Mm, if it is linear ulcer, CMV. If it is vesicles around roveoid ulcer, it is herpes. If it is white plaque, candida, and sometimes comes with the actus ulcers, where there is a symptomatic treatment should be needed. So about that is all about. Hope you enjoyed.